Hello, my name is Melanie Verbrugge, and this is my presentation about my project, Improving Dental Implant Success Rates for Patients Allergic to Penicillin. Committee members involved in this project are Dr. Sabrina Condon, Dr. Marilyn Riley, and then Dr. Luke Fremmel from the clinical site. To start, background and significance. Infection is a major causative factor in dental implant failure and needs to be treated with the utmost importance. If infection is not prevented, breakdown of the bone at the implant site occurs, causing the implant to fail to integrate. Removal of the implant as soon as failure is identified is crucial to preserve bone in the area and prevent further bone loss. And that comes from Kochar et al. 2022. Infection at the site of the implant is one of the most common and avoidable causes of implant failure. Because infection is preventable and treatable, the optimal antibiotic must be administered. Standard guidelines for antibiotic therapy do not exist currently for dental implant patients. Most often, amoxicillin is given, but it is not an option for patients who report a penicillin allergy. So here is this chart that we can take a peek at. Dental implant failure was reported in 8.4% of patients who did not report a penicillin allergy, as shown here, compared to 17.1% of patients who did report an allergy. And that comes from Bagheri et al. 2022. One possible reason for this discrepancy is suboptimal antibiotic therapy for patients with penicillin allergies. Clindamycin and cefuroxime are two options for these patients. This study examines the success rates of these antibiotics and aims to identify which is linked to higher rates of implant success. Review of the literature. Starting with strengths, study designs. Research designs included in this project included 2 observational studies, 7 retrospective cohort studies, 2 randomized controlled trials, and 1 cross-sectional study. Ethical studies and research included in this review report the approval from some ethics approving body associated with their research, be it from the organization or a hospital, something like that. Diversity of subjects. Wilson et al. 2023 included Veterans Affairs Health System patient population. Camps-Font et al. 2018 featured study subjects receiving implants from the dental clinics at the University of Barcelona. State et al. 2020 used a patient population receiving dental implants in a private practice setting by the practice's 2 oral surgeons. The research included represents a variety of practice settings from public health institutions to private practice clinics in areas across the globe. Weaknesses. Retrospective cohort studies. So this research design still qualifies as a type of primary research. However, it is weaker than other research designs. This research group only contained 2 randomized controlled trials, illustrating a stronger relationship between cause and effect in the test group and establishing a baseline with the control group more effectively. Small sample sizes were another weakness in the literature. So when the sample sizes are small, findings may only be applicable to some of the population as efficiently. Zhang et al. 2024 utilized a sample size of 284 patients, with 2 subgroups, each only containing 128 patients and 156 patients respectively. Yaramseti et al. 2023 had a sample size of 80 study subjects with 100 implants placed. These small sample sizes make broader generalizations of the findings almost impossible to apply to a larger and potentially more variable population. Gaps. So in the gaps, there's no recognized protocol. So an internationally or nationally recognized protocol for administering prophylactic post-procedure antibiotics in dental implant patients has yet to exist. Most often, the choice to prescribe antibiotics is determined by each provider. And with the present lack of evidence supporting or disproving their effectiveness, practitioners are reluctant to recommend them. Much of the selected research involved topics related to this project's clinical question, but few studies directly examine the effectiveness of different antibiotic therapies in dental implant patients. Limitations. Cross-sectional data. A large majority of the research compiled for this project was cross-sectional and did not inform on the longitudinal effects of the intervention. Longitudinal data is required to determine the effects of an intervention over time. Another limitation is that some of the research was not widely applicable. Because of small sample sizes, the studies used for this project are also limited in that they cannot easily be applied to the general population. Although trends were able to be observed in the studies, those conclusions cannot be applied to the majority of patients receiving dental implants due to the lack of diversity and lack of breadth of the sample. Theoretical framework. The model that most closely aligns with the aims and focus of this project is Pender's health promotion model, developed originally by Nola Pender in 1982, with subsequent revisions thereafter. Pender, 1990, notes that health is frequently pared down to simple terms, like the presence or absence of disease. Now, this view of health is immensely limiting and does not consider the nuances of each patient as a person. Later research expands on Pender's original model. One such research team, McCutcheon et al., 2016, report that pressures from culture and society, paired with personal attitudes and beliefs, make up a person's overall health and wellness. All these factors must be considered when assessing a patient's health. Pender's health promotion model informs this project because it helps to explain how patients come to need dental implants and extensive dental rehabilitation. Often, patients present to oral surgery clinics and appear generally healthy. Providers may fail to consider the factors that led a patient to poor oral health, missing teeth, and indentualism. For example, Tawari et al., 2022, note that poor oral health is strongly correlated with mental health issues. This links to Pender's model because patients may seem healthy at surface level assessment, but may be dealing with factors that cannot be seen. Patients may have a history of traumatic life events that put a strain on their mental well-being and lead them to fail to prioritize their oral health. Lack of proper oral health practices can lead to gross decay and the need for tooth extraction and replacement with a dental implant. This project aims to keep these considerations at the forefront to improve outcomes for patients getting dental implants who have a penicillin allergy. Methods and design. This project follows quality improvement guidelines using quantitative data collection to determine if a relationship exists between improved implant outcomes and the administration of cefuroxime as it compares to implant outcomes and the administration of clindamycin. So again, it's a quality improvement project including two groups, the intervention group, who received cefuroxime in the immediate postoperative period, and the non-intervention group, who consisted of a retrospective chart review of dental implant patients who received clindamycin in the immediate postoperative period. Patients undergoing any type of procedure at the oral surgery group must complete a medical history and demographics form at their initial consultation appointment. The information from these forms is then input into the patient's electronic medical record, EMR, at that time. The EMR flags any patient allergy input into the system with an allergy warning on the patient's chart. These allergy flags on patient EMR were used to identify patients for participation in this study. Patients who received dental implants and were identified with patient penicillin allergies from February 2025 to May 2025 were part of the intervention group and were given cefuroxime for infection prophylaxis in the immediate postoperative period. A retrospective EMR was conducted of patients who received dental implants and were identified with patient penicillin allergies from December 2024 to February of 2025. Once participants were identified, patient identifiers were removed from data collection to preserve the privacy and safety of each patient. Procedure, penicillin allergy status, and implant outcome were the only data used in this study. Success or failure of the implant was based on a standard method at a follow-up appointment approximately 10 weeks after implant placement. Implants were deemed successful if they met the following criteria: positive bone growth present around the implant determined via radiography, and that the implant remained firm with the pressure of a manual torque test. Now, these qualifications came from Karthik et al., 2013. A successful implant was represented with a value of 1, while a failed implant was represented with a value of 2. This data was collected using Excel spreadsheets, one for each patient population. The first spreadsheet contained data on those patients who received clindamycin, and the second spreadsheet contained data on those patients who received cefuroxime. Patients were numbered on a consecutive basis until the ideal sample size is reached, at which point data collection ended. So here is an example of the data collection tool created for this project. Again, patients on a consecutive numeric basis, and then the results of their implant testing with a 1 or a 2 denoting a success or a failure. Protection of human subjects was of utmost importance for this project. One risk involved in this project was the potential for breach of confidentiality. To protect patient identities, several steps were taken. Data was recorded on a computer at the clinic that is login credentialed and password protected. No data left the clinic unless it was de-identified. The site where the project took place was simply referred to as a Midwest Oral Surgery Clinic, and patients of the project were identified collectively as patients. Data in hard copy was shredded, and electronic data was deleted from all drives on which it was stored. Sample. Inclusion criteria. The following conditions must be met for the patient to be included in this study. The patient must be 18 to 89 years of age, must be undergoing dental implant placement, must have a reported allergy to penicillin, must be able to provide procedural consent for themselves. Patients of all religious and ethnic backgrounds will be included, and patients of any native language will be included as well, utilizing interpreter services if needed. Exclusion criteria. Patients will be excluded from participation in this study if the following conditions applied: if the patient was 90 years or older, if the patient was under the age of 18, or if the patient was unable to provide procedural or informed consent for themselves. So here is just a little pie chart representative of the sample sizes of each group. The clindamycin group, shown in blue, consisted of 64 patients, and the cefuroxime, shown in red, consisted of 110 patients. Now on to data analysis. Many types of data can be used to investigate questions related to this project and the most appropriate antibiotic therapy for penicillin allergic patients. Shedden 2020 notes that nominal data is a type of data that is categorical in nature and has no meaningful system of ordering. The data collected for this project is nominal because successes and failures are notated as either a 1 or a 2, grouping them into categories with no hierarchical order. To analyze the data for this project, Microsoft Excel and the Statistical Package for Social Sciences, SPSS, was used. Data was collected and input into Microsoft Excel for organizational and formatting purposes. For analysis, this data was taken from Microsoft Excel and put into SPSS. These programs were selected because of their compatibility and the ease of use for data analysis purposes. The type of statistical test used for data analysis of this project was the z-test for the difference of two proportions and the directional form of a chi-square. The z-test for the difference of two proportions is used to compare the proportions of two populations and determine if there is a statistical difference between the two groups. The test was run first with the data from the group of patients who received clindamycin. The resulting data included a proportion of successful implants in patients who received clindamycin over the entire number of patients who received clindamycin. Similarly, the test was run with data from the patient group who received cefuroxime for infection prevention. The resulting data included a proportion of successful implants in patients who received cefuroxime over the entire number of patients who received cefuroxime. These proportions were compared to determine if a statistically relevant difference existed between the clindamycin and cefuroxime groups. Once it was determined that a difference existed, the directional form of a chi-square was used to determine if the relationship between the antibiotic, cefuroxime, and implant success is positive. The independent variable in the data analysis, which is the antibiotic, clindamycin, or cefuroxime, was used. The dependent variable was whether the implant placement was determined to be a success or failure. Based on the desired testing, the sample size would have been ideally about 154 patients to result in a power of 0.80 or higher. Moving on to results. Descriptive statistics were used for analysis of the data to provide a summary of the data in this project. The data from the clindamycin group and the cefuroxime group were compared using descriptive statistics. The cefuroxime group consisted of 110 patients, shown by this pie chart here. Of those, 93.4%, or 103, resulted in implant success, while 6.4%, or about 7, resulted in implant failure, again shown in this pie chart here. The clindamycin group consisted of 64 total patients. Of those, 73%, about 47, resulted in implant success, while about 26.6%, 17, resulted in implant failure. Data analysis determined that a relationship did exist between implant success rates and cefuroxime administration. The cefuroxime group had statistically higher success rates of about 0.94 than the clindamycin group, 0.73, and the values for that were Z equals 3.7259 and the P of 0.86 to 1. Moving on to limitations. So bias is a limitation of this study and might have been present in a couple ways. The setting of the study was a Midwest oral surgery clinic that uses implant success as a metric that is closely followed, as implant failures are really costly to the practice. It is possible that because the staff were aware of the study and its participants, and that implant failure is viewed negatively, the staff behaviors may have changed when interacting with participants. A design imperfection in this study is that the researcher, me, was not present for all instances of patient education. Because of this, information may have been delivered differently by different staff members, even though a standard education was provided. A standard method of determining implant success was determined, but nuances from surgeon to surgeon do exist. It's probable that if an implant did not meet standards, but did not show signs of infection, a surgeon may allow additional healing time beyond the 10 weeks as described previously. Additional healing time was not part of the standardized method outlined for the study and may lead to results that are not reflective of the intervention, but are because of longer healing times. Education was provided to all staff and surgeons regarding the determination of implant success to mitigate this limitation. However, there was no method for reporting deviations from the design as it was planned. For future research efforts, a plan for reporting changes from the study design must be included to ensure that an accurate picture of results is able to be achieved. The study, as it was designed, applied well to the setting it was conducted, but may not be widely generalizable to other sites. Additional time must be added to clinic workflow to provide patient education and address patient questions and concerns. Participating clinics must have an electronic medical record system that allows input of medication allergies and provides a way to denote patients who report a penicillin allergy. Participating clinicians must also be willing to require a minimum 10-week healing period and require patients to return to the clinic for final implant checks. This return appointment provides an opportunity for patient attrition. The study demonstrated a positive relationship between cefuroxime and implant success when compared to clindamycin. However, this may have only been possible because the study was designed with the specific clinic workflow in mind. On to discussion. Based on the findings from the review of the literature, this author hoped for a correlation between cefuroxime administration and increased implant success rates. There were no studies available that examined the specific scenario, which made it difficult to form an expectation of outcomes for the study. The data from this study showed a strong positive relationship between dental implant success rates and the administration of cefuroxime as compared to clindamycin. This is consistent with information presented in the literature review. A suggested causal mechanism for the results of this study is shown here, and includes that cefuroxime adequately prevented postoperative infections while not affecting bone growth around the implant, leading to implant success. Comparatively, clindamycin, while preventing infection, also negatively may affect bone growth around the dental implant, which could lead to a failure of integration. A way to improve outcomes in the future would be to verify that patients take their prescribed antibiotic as directed. This would be achieved via a follow-up phone call to ensure compliance with antibiotic therapy and would provide additional opportunity for patient education regarding the importance of antibiotics in preventing postoperative infections. Implications for practice. The findings of this project suggest that there is a positive relationship between cefuroxime administration and dental implant success. These results might impact future research by warranting additional research on the topic. Researchers may want to explore why cefuroxime is more effective for dental implant infection prevention. They may also want to explore other antibiotic options to determine if there are other therapies that may be more effective than cefuroxime. These findings might impact future practice by influencing oral surgeons to consider cefuroxime for this patient population. Current standardized practice guidelines do not exist for antibiotic administration after dental implant placement. This project provides evidence that cefuroxime is a more optimal antibiotic therapy than clindamycin for patients with penicillin allergies who receive dental implants. With this evidence, policymakers can choose to publish guidelines that help standardize the procedure for infection prevention in this patient population. The findings of this project may help to guide future policy to include utilizing cefuroxime instead of clindamycin for infection prevention. The policies could eventually go on to include dosing and duration guidelines for the cefuroxime administration, and these policies could then be used by oral surgeons around the globe. Moving along to conclusions. So a short summary, the goal of this project was to improve implant success rates in patients with reported penicillin allergies and to determine if cefuroxime was linked to higher success rates than clindamycin. This study resulted in a statistically significant evidence that cefuroxime is linked to higher rates of implant success than clindamycin. Current research had not directly compared the two antibiotics in this way before. Impact of this project. This study highlighted the lack of a standardized protocol for antibiotic administration in post-procedure dental implant patients. A review of the literature demonstrates that infection is the most common and preventable cause of implant failure. A standardized protocol could directly address post-operative infection. This study illustrates the need for further research on which antibiotics are most effective and why some antibiotics are less effective. Additionally, other factors such as patient health, smoking status, age, etc., should all be examined to determine their effect on implant outcomes. This study is a small effort at examining the larger picture of cause and effect that lead to successful dental implants. Improvements. Ideally, this project would have taken place over a longer period of time to get an even larger sample size. A larger sample provides a more robust data set and would be more indicative of the general population. Additionally, if this project could be implemented at other oral surgery clinics, researchers would be able to determine if the results are repeatable and add to their validity. Future goals. I plan to share this information with the surgeons and staff at the practice where this project was implemented. At the very least, I really hope it will spark conversations about ways to improve implant success and improve patient education regarding antibiotics and implants. Ideally, the surgeons of the practice will use the conclusions gleaned from this study and consider implementing a standard of antibiotic therapy for dental implant patients at the practice. Perhaps they would even discontinue the use of clindamycin and opt for cefuroxime instead. DMP impact. So this program really has had a profound impact on me. I was never really interested in statistics or research and development piece of the healthcare system. After taking a statistics class with Dr. Powell's, I discovered that all research is not created equal and should not just be taken at face value. This program has really taught me to question research and really just look at the facts before simply accepting conclusions that a researcher presents. I think this is going to serve me really well as a practitioner because it will require me to do my own research and literature reviews before implementing new methods, medications, etc. Into practice and making those recommendations to my patients. Additionally, this program has taught me just how much effort and time it takes to develop, plan, and execute a scholarly project. In conclusion, this is a slide of the references used for this presentation. Thanks for watching.